you're most welcome. And hopefully we can have speakers from both sides and from outside as well, who are world-renowned speakers. Doing well. How's everything? How is
Good.
Turkey? Turkey is okay? No more lockdown?
No, there is a slight increase in the numbers of COVID cases.
Yeah.
We are scared, but still working. Normal routine work.
Yeah, unfortunately, the numbers have been growing in Spain and France and Germany. You know, average deaths per day have been 300 in each country. Actually, it's quite bad.
How is it in Pakistan?
It's actually quite good. The total number of deaths yesterday were 12, only 3 in our province. So although the numbers have been about 700-800 every day, but you know, generally it's mild disease, and we are doing very few tests because, you know, people know that they're asymptomatic, so they wouldn't worry about it, or, you know, very, very mild symptoms.
Right.
Ahmad, do we have a pre-quiz and post-quiz, or just a post-quiz? What have we got?
Sir,
Yusuf?
only the post-quiz.
Only the post-quiz. Okay, good. And for people who are already connected, so obviously once Professor Mehmet Zileli has given the talk, you know, you can write questions on the chat and ask. Doug Orr from Cleveland Clinic is going to be sharing some cases after Mehmet. And also we have Mike Steinmetz said he will try to join as well. And as
it should be very early for them. Am I right? For the US, it should be very, very early.
It's Sunday morning. Let me see.
Not 5:17. Yeah, 7 hours difference for New York from us. Then it is 10 o'clock.
And I see Stacy here as well. Welcome, Stacy. So it will be early in the morning for them, Mehmet, but it's unfortunately Sunday, but you know, it's quite late because then we can't have people from Indonesia and Korea. So they can't come in because it's otherwise very late for them. So Stacy actually wrote a paper for us for the deformity book. She's actually was working in Belfast, now in Dublin, as far as I know. Okay, good. You're welcome. Mehmet, how's the boat? Are you still going on the boat, or you're off for some time?
I was on the boat from Friday till now, and I just came home.
I can see the red blush glowing on your face.
Yeah, it is still mild weather.
Yep.
Actually, it's at the end of October. It gets colder, but it's still warm. I guess we will not be able to make live meetings even for March, April next year.
You're right. We postponed our WFNS international meeting in Karachi in November to February, but the feedback that I'm getting from Europeans is that it will be very difficult for them to travel. So I think we probably have to postpone maybe till May, or maybe postpone a whole year before we do that meeting. I think at the moment it's looking very dodgy for next, at least till March, it's looking very dodgy.
Right.
Let's see if any of our hosts have come in. Imad, any of the hosts? Yusuf, have you had a chance to write to Michael Feeling, and did you get a reply from him regarding after a fortnight. Yusuf, are you there? Let me see.
Yes. No, I have not. I have not had the opportunity to talk to him yet.
So could you please email now, and you never know, you might get a reply. So while we are busy for next 60, 70 minutes.
Okay.
Yes.
Okay.
Okay. And let me just call Nikolai because he was on the phone to me about.
Sir, he told me he's driving back home from
Oh,
hospital. Yeah.
okay. So in 1 minute we can start, Mehmet. You agree?
Okay.
Okay. While we are waiting, there are many trainees and residents here at this time. Well, what part of spine would you like to have talks in? If you could just write on the chat so we get just a feedback of what we are doing and how we should improve these webinars.
Well, doesn't matter actually. I'm more involved in all parts. But recently, I do mostly the degenerative spine, which is more common in our practice. So then I see more defects in learning. We are making more mistakes in our daily practice of degenerative spine. There are some interruptions in the internet connection. Am I right?
Yeah, you're right. There is.
It comes from my side or your side. I don't know.
No. This. Imad, can you check or change the Wi-Fi that we're working on?
Sir, mine is working fine.
Okay.
Mm.
I'm just going to change my Wi-Fi to hotspot.
It's some friends are saying deformity correction. Actually, we will have a deformity webinar symposia very recently because the Bangladeshi friends wanted to get this, and I think it is in 11 November. A deformity correction webinar. There will be four different speakers.
Yeah. So we have that. Besides that, we have the cervical trauma. We are doing cervical trauma with the group in India with Icherion, and we are doing it with WFNS Spine Committee. But surely we can add these on top of what we are doing already. We have had a couple of talks on anterior approaches, but I think Paulo Pereira will be giving a talk in about a month's time, so he'll be talking on those anterior approaches. Okay, so I suppose, Mehmet, we are okay to start. Dear friends, it's really my pleasure to have with us my dear friend for about 20, 25 years, Professor Mehmet Zileli. We've spent a lot of good time together, teaching, training all over the world. And especially with these webinars, he's been really a force who's pushed us in doing many things. He's made us write chapters and papers and guidelines, and that all has worked really well for people all over the world. So I'm grateful. Mehmet, you're doing a great job. So Mehmet today is going to be talking about, he's the chair of the WFNS Spine Committee, and he's going to be talking about fusion versus non-fusion. Mehmet, all yours.
Yes, I'm sharing my screen.
Sure.
Is it there now? The screen?
It is. You want to play it like with all this, or do you want to just make it? Because at the moment, yeah, full screen going. Thank you.
Is it full screen now?
No, it's not.
It's not. I don't know how did it happen.
Could you go on top where it says display setting in the middle?
Yeah. Yes. Is it now?
Yeah, it's perfect now. Thank you.
Okay, good. Now, in this talk, I will try to discuss when to decompress and when to fuse in lumbar spine stenosis. This is a very hot topic. Actually, in practice, I'm seeing that many spine surgeons are trying to fuse many of the cases of lumbar spine stenosis. First, some background information about lumbar spine stenosis. Stenosis or narrowing. Probably narrowing is a better term. Stenosis term comes from myelography era. And the main problem with this disease is neurogenic claudication. Low back pain may be added to that or not. There are congenital type, which is more common in younger ages, and very more common is degenerative disease. Acquired ones are in the older ages. There are anatomical terms like central stenosis, lateral or foraminal stenosis, and the frequency of the levels is most common is L4-5, then the second most common 3-4, then 2-3, and L5-S1, quite less common in the lumbar spine. The motion segment terminology is something that the disc space and adjacent end plates and two facet joints compose the motion segment. And if you look at the degeneration phases, there are mainly three phases described by Kirkcaldy and Willis: dysfunctional phase, unstable phase, and stabilization phase. This is the graph that we are having, that first dysfunctional, unstable, and rest stabilization. If you look at here, for the rest during the rest stabilization phase, we must not do any fusion surgery. Just decompression will be okay. But in one patient, there may be different levels, which one level is unstable, the other level is rest stabilization phase, another level may be dysfunctional phase. Normal mobile segment is like this, but if it is degenerated, then the disc height is decreased, ligaments laxed, and facet joints overloaded. In fact, there is no ligament hypertrophy because of ligaments laxed and shortened. We see the ligaments like they are hypertrophic. This table explains how we can call a stenosis like soft stenosis, after a while a dynamic stenosis, and after some rest stabilization phase, a hard stenosis. These are relatively pathological terminology, cannot define our daily practice every time. Surgical indications are mostly relative, almost more than 95% neurogenic claudication. Absolute indication is cauda equina syndrome. It's not very common. It's quite rare. This patient, a 32 years old male, came to me with a urinary incontinence for 5 days and perianal sensory loss. It was a real cauda equina syndrome, but this patient has a unique feature. It is a congenital canal narrowing. There is almost no pedicles or very short pedicles. Surgery is absolute indication. There are mainly two techniques. One is the decompression, open or MIS techniques. The other one is decompression plus fusion. It may be done without instrumentation or with pedicle screw fixation plus interbody fusion or post-rectal fusion. In the past, we used to do total laminectomies. Then we tried to make fenestrations so then we were preserving the spinous process and a part of the lamina on both sides. But to do that, we were opening the muscles, retracting the muscles on both sides. This is one typical fenestration, postoperative AP film of fenestrations. Then the recent trend is to protect ligaments, facet, and avoid instability by looking the canal from one side, so unilateral approach and bilateral decompression. This is the new trend. It may be done by a microsurgical technique or tube-guided surgery, which I had explained that in other webinars. Tube-guided surgery facilitates our view. You can either use endoscope or microscope. You can make, this is 2 levels decompression before surgery and after surgery with unilateral approach from one side only. Even 4 levels is possible. This is preoperative films of that patient, 4 levels, and this is postoperative films. Yes, preoperative and postoperative, post-op. We must, however, stress the facts about the MIS decompressions. This is an effective and safe choice for surgical decompression. However, it is not superior to the open decompression in terms of clinical outcomes. If you look at many good clinical series, there is not much difference with clinical outcomes. However, hospital stay and return to work are shorter. Infection rate is less. This is quite well shown in many studies. And small modification of conventional instruments and one of the advantages of tube-guided surgery is the learning time is shorter. When fusion is necessary, somebody says if you create iatrogenic instability, extensive facet resection and or 3 levels total laminectomy, degenerative listhesis plus back pain, degenerative scoliosis plus back pain, flat back syndrome, these are the indications for fusion. Probably this is right, but we will discuss it. There is one term which I like to use, the complex lumbar spine sections with degenerative listhesis, scoliosis, kyphosis, previous lumbar spine surgery, postoperative adjacent segment stenosis, and radiological instability. So this is typical case of flat back syndrome. This is the lateral X-ray of that lady and spine stenosis. And probably we should make an 4-5 osteotomy and TLIF, instrumented fixation and fusion decompression. What are the surgical options for degenerative listhesis and stenosis? We can still make some decompression alone in some cases. Decompression plus fusion in different techniques, decompression plus dynamic fixation. What is the decompression alone indications in degenerative listhesis and stenosis patients? If it is a stable segment with osteophytes, anterior stasis less than 3 millimeter on dynamic radiograms, and significant loss of disc space, probably less than 2 millimeter disc height, and no movement. These cases, although there is some degenerative listhesis, are candidates for decompression alone surgery. What about decompression and instrumented fusion in degenerative listhesis? If the anterior listhesis is more than 3 millimeter, mobility in dynamic films, preserved disc height, sagittalization of the facet joints, no osteophytes, osteoporosis, females, obesity, hyperlordosis, laminectomy on more than 3 levels, and additional discectomy. I will not mention about the techniques used. This is somewhat far from my object on this talk, but I must mention dynamic fixation. Some surgeons prefer to use it to avoid the problems of fusion and the morbidity and adjacent segment degeneration. But there are still some cautious things that do they really prevent adjacent segment degeneration or not? We don't know yet. What about the evidence for surgery? Actually, although my talk aims to make fusion or not, we can first ask if there is a need for surgery, any surgery, even decompression. So this study from 2008, a well-designed randomized cohort study with sport investigator and very famous orthospine surgeon Weinstein, 289 patients randomized cohort. Surgery is superior to non-surgical treatment, and it is probably an early study which is stressing the surgery is superior. This from 2017, collecting 5 studies comparing surgical versus non-surgical treatment, 643 patients. They had no conclusion regarding which treatment is better. However, side effects of surgical groups are between 10 and 24%. So complications are quite much with the surgery than the conservative treatment. So then they decided well-designed studies are necessary. Another study from 2016 with conservatively treated patients, 3-year follow-up, they say that 30% subjective improvement of symptoms without any treatment. 70% symptoms remained unchanged, worsened, or required surgical treatment. So we can tell that even with conservative treatment or follow-up, simple follow-up, 1/3 of the patients may improve by the time. So it is the WFNS spine committee's recommendations about the natural course. Approximately 30% of patients with lumbar spine stenosis are expected to worsen, but 30% may improve with conservative measures. So predictive signs and symptoms that they will worsen are dural sac cross-sectional area less than 50 millimeters square, presence of radicular symptoms and back pain, degenerative listhesis and or scoliosis, and symptom duration more than 1 year. These are predictive signs that the patient may worsen by the time. What about the evidence for fusion surgery? Shall we choose decompressive surgery or fusion surgery? One study from 2015, a meta-analysis saying that decompression plus fusion is not more effective than decompression alone. Another statement they have shared in conclusions that the interspinous process spacer devices result in higher reverberation rates than bony decompression. So they say that these devices are not good. In Epstein's 2016 study, a retrospective analysis in elderly patients, mean age 72, she says that direct radiograms of the geriatric patients may show grade 1 or 2 listhesis. It doesn't mean they are unstable. They may have fused and not necessary to instrument. 80% of instrumented fissures at this age group require reoperation in 5 years. Even if there is instability, they rarely need instrumentation, and she stresses that the 1 to 2 level non-instrumented fusion is better than instrumented fusion. It's something with not very high evidence level.
Sorry, Mehmet.
Yeah.
Your voice is just, there's a lot of noise. Maybe it's the microphone that you're using. Could you just adjust it a bit?
Is it?
Just the microphone, just see what but there is some noise along with your voice. So let's see. Okay.
Okay.
So just again, we do that.
Okay, sorry for that.
I'm sorry.
Sorry,
you need to go back on display setting. Yeah, that's it.
Okay.
Sorry to bother you.
This study from a Swedish group, which is one of the most cited publications from 2016, is saying that decompression plus fusion surgery did not result in better clinical outcomes at 2 years and 5 years than did decompression surgery alone. So there is no difference at all, which is a level 1 evidence, a randomized controlled trial of fusion surgery or decompression surgery. Another study, 2018, one level lumbar spinal stenosis and degenerative listhesis at L4-5 level only. They have divided 3 groups: from decompression alone, decompression plus fusion, decompression plus stabilization. 85 patients randomized, total follow-up 5 years, no difference in outcomes at 1 and 5 years. And fusion and stabilization group had more blood loss, longer surgical duration, and longer hospital stay. And they concluded that the additional instrumentation for low-grade degenerative listhesis did not result in superior outcomes to decompression alone. This study by Salman and our group, WFNS Spine Committee recommendations, there are 3 recent comparison studies, RCTs, which shows that there is no difference between fusion and decompression. So these are our recommendations. And we say that in patients with lumbar spine stenosis and no sign or symptoms of instability and predominant leg pain, decompression alone is recommended. If it is a stable spondylolisthesis, we use this term to define that the disc height is very low and there are osteophytes and there is no movement with the flexion extension films. Fusion is not mandatory and decompression alone is suggested. However, unstable spondylolisthesis cases with symptoms may require fusion. We are not stressing that they must be fused. There is no consensus if the main complaint is mechanical axial low back pain, which is more than leg pain. The patient may benefit from a fusion surgery. Patients with lumbar spine stenosis and loss of sagittal balance, if symptomatic, may benefit from decompression fixation and deformity correction surgery. Fusion may be advisable in patients who undergo bilateral facetectomy of more than 50% and bilateral discectomies. And facet joint effusion alone is not proven to correlate with stability. These are our recommendations. But I like this study, and I wanted to show this Kulkarni, orthopedic spine surgeon from India, a very recent paper. He has graded the clinical factors and radiological factors and technical factors. And he says that if there is mechanical back pain, score is 2, age younger is 1, segmental kyphosis is 1.5, segmental dynamic listed is 1 point, disc height is preserved 1 point. So then if the points are more than 5.5, this indicates instability, and those cases should better go to fusion surgery. This is one scoring system to help our decision making in lumbar spine stenosis, whether we have to fuse or not. In conclusion, non-surgical treatment for lumbar
Sorry, Mehmet.
For some reason, I can see that Mehmet is muted.
Let's see if we can fix that. Mehmet, sorry, you're muted and we can't hear you. I'm trying to unmute you. Imad, can you fix that, please?
Sir, I am asking him to unmute. Yeah, he has one. Yeah,
Sorry, Mehmet, you need to show your last 3 slides, conclusion slides, because you were muted. Sorry, we're trying to fix this.
Okay. Screen sharing is still there?
Yes, you can just show our last couple of slides. Thank you. Because we could see the slides, but we couldn't hear you. Dagor has arrived here as well. Nikolay is here as well. Welcome, Nikolay.
Hi, I think some confusion happened probably because they returned the time 1 hour back. Sorry that I'm late.
Fair enough. Yes, Mehmet.
Did you hear this scoring
Yes, we
system?
did. Yes, we did.
Okay. So then, in conclusion, non-surgical treatment for lumbar spine stenosis may still be a good option for many patients. Decompression is the basis of our surgery. Indications are mostly relative indication just for claudication and to increase the quality of life of the patients. Unilateral approach, bilateral decompression is currently most popular surgery, but its value is not validated yet, unfortunately. MIS techniques for spine stenosis have some advantages, but in the long term, the outcomes are same with open surgeries. Fusion is an option, especially when listhesis or instability are present, but indications remain controversial. And in degenerative listhesis, decompression without fusion is still possible. And decision-making for complex spine stenosis is more difficult. And fusion indications, back pain, overt instability, preserved disc height, and facet degeneration may be like those, but still not very clear. Better we must perform shorter fusions, and fusion surgery has more complications, up to 25% complication rate. There is no good correlation between radiology and symptoms, and our decision must be based on our clinical symptoms, not the radiology. This is my own algorithm for neurogenic claudication and lumbar spine stenosis. First question must be if there is a back pain. If there is no back pain, just decompression. Whether you see a listhesis or not, doesn't matter. With back pain, if there is no instability, you can just try facet injection, sacroiliac joint injection, brace and exercises, so conservative measures. If there is good benefit, you can make the patient as candidate for decompression only. If no benefit, so then decompression plus fusion may be indicated. A patient with back pain and significant radiologic instability, that patient may go to decompression plus fusion. Okay, I thank you for listening to me. Our Istanbul Spine Masters has been postponed to next year, September 16 to 19, 2021. Thank you for listening to me.
Thank you, Mehmet. Brilliant talk. Nikolay, you'd like to take over? Sorry, since Nikolay wasn't there, so I just took the liberty of starting this. Professor Dagor is here as well. Stacy is here to present as well. So I think we're going to have good fun. Atul Gol, I can see in the audience as well. So Nikolay, all yours.
Thank you so much. And thank you so much for taking over, Salman. And again, apologies for being late. I did not calculate the 1 hour back, and that's the reason. Excuse me for that. Mehmet, at least the part that I've seen, good and very comprehensive talk as usual, and thank you so much for that. I will I will ask you a few questions if you don't mind. I don't see any questions in the group chat, so I'm gonna take the liberty to ask you. First, I completely agree with you and with your algorithm that if there is no back pain, probably simple decompression will be good, and that's my practice as well. And whatever I see, unless it's really striking radiological instability, then I will also just simply decompress. But my question is, if you still have some concerns whether there is decompression or whether there is instability or not, do you follow these patients with dynamic X-rays post decompression? Do you do standing X-rays just to see if there is any instability? At what stage do you do that? And my next question is, if there is only back pain, do you consider sending these patients for ablation procedures? And what's your practice with that?
Yeah. In my algorithm, I have shown some injections and conservative measures. If there is back pain predominantly, but no instability signs, so then those patients may first get some injections or conservative treatment. If it doesn't work, then they may be candidates for surgery. For your question about the following patients with dynamic films, I don't do that actually, because in no case we see that significant instability develops. I mean, more than grade 2 listhesis, I didn't see in degenerative listhesis. Although somebody mentions that it may happen, but I didn't see any grade 3. If, however, the patient is not satisfied because of the back pain mostly, we must evaluate the patient once again. That's my policy.
Okay, I personally seen a few patients where I've seen radiological signs suggesting possible instability, but as you said, no back pain, and I have just decompressed. And then on the follow-ups, not so many of them, but I've seen a few which developed lately, more radiological and also clinical signs of instability, and I had to go back and fuse. Maybe I have to audit my practice and see really what is the percentage of that. Not so many, but I have seen a few cases where I've done postoperative standing x-rays on the first follow-up, which is normally 6 weeks for me. And then I've seen more listhesis than it had been before, and the patient is not happy with back pain, which developed after the surgery and persisted and sometimes got worse. And not so many, but a few cases I had to go back and fuse.
Right. Yeah, it is. It is possible.
And then if I inject and if they have a short-term relief for my back pain only patients, I consider sending them for ablation procedure. And some of them just get away with ablation without fusion. That's why.
What is some of them, Nikolai? What percentage would get better?
Right. So I basically would go and send for ablation, and I do ablation, endoscopic ablation myself. And I have not audited my practice as yet, what exactly percentage, but surely over 50% of them will get good outcome for their back pain, which is still significant for me because I do a very minor day procedure and they get away without anything more significant like fusion.
Okay.
If I might add a couple of things. One thing that wasn't brought up, the Gogawala study that you mentioned, Mehmet, specifically excluded anybody with an unstable spondylolisthesis. Yeah. So that if they had motion either on flexion extension or between supine and standing imaging, they were not entered into that study. So that's Gogawala study was all stable spondylolisthesis. And they actually did show in a couple of the secondary outcomes, improved outcome with fusion. So that's not one that I think you can say it didn't show a benefit. It certainly did, but not in the primary outcome, which was the SF-36. A study that I remember, it's one that I saw Keith Bridwell present, but never publish. He did one of the early studies looking at laminectomy alone versus laminectomy and fusion, and showed a benefit to fusion as opposed to laminectomy. But what was interesting is he went back and he subgrouped who did better, like who did well amongst the non-fusion patients. And the ones I remember is older patients. So again, you're older than 70. The loss of disc height was a predictor of good outcome of decompression alone. But the other one that doesn't get mentioned a lot was actually the slope of the L4 superior end plate. If the L4 superior end plate is parallel to the floor, they had a very good outcome with decompression alone. If it was sloped more than 10 degrees, they had a very bad outcome. So those are a couple of things that I add into my decision to decide whether to fuse somebody or not.
Thank you. Good comments. Thank you. What do you think about that scoring system, Doc?
I guess it's one of those ones that we're probably all mentally doing that in our heads anyway. We just never got bothered to put numbers to it. You know, I don't. That system is out there, but it hasn't been tested.
I looked at the scoring system and I used it in a couple of my patients. I think we can improve it further, and I spoke to Arvind about it. And I think it's possible that it can be improved further to refine it a little.
Yeah.
Okay. Mehmet, any more comments? Any questions from the audience?
There were a couple on the chat I saw.
Yeah, so patients who have suffered stages, unstable and restabilization, how would you approach this group of patients?
Sorry?
Mehmet is talking about patients who have different stages, i.e. unstable and then restabilize. So
Yeah.
how would you approach those patients?
This is actually quite common. One of the disadvantages of fusion surgery is adjacent level disease. So it's more common if you do multiple levels, adjacent level disease. Because of that, you must do your fusion as short as possible. Or a dynamic fixation may be used. For different stages, for the other level, you can make just injections. You can stay conservative for the other levels. You don't need to correct all the degeneration. Actually, degeneration is something normal. Probably we will have in the future some other management tools for against degeneration. We will do it better, but all the degeneration should not be treated by surgeons especially.
Mehmet, there's another question. What about severe stenosis with facet degeneration? If it's more than 2 levels, would you suggest fixation fusion in those patients with the facet sign that you have with arthropathy and on top of it severe facet degeneration? So would you fuse these patients or would you consider just decompressing?
Yeah, Arvind Kulkarni has mentioned this also. He is telling that it is unfeasible to make a good decompression without removing facet joints. Is there such cases really? It depends on your surgical technique. So I don't agree with that point. He has then pointed that 1.5. But having said that, only removing facets in 2 levels doesn't mean that it is really unstable after surgery. So it is just 1.5. He was saying that it must be 5.5.
And there is research suggesting that if you keep the midline structures, let's say if you go on unilateral, if you keep the midline structures, if you keep the disc, even if you remove one facet completely in the lumbar spine, then the chances of developing instability is less than 2%. So we still, and also that also depends on other factors like disc height and the mobility of the disc, obviously. But yeah, so it's, the facet is important, and if we can keep it, maybe it's good. But I don't know what you think about this, Mehmet.
Yes.
And again, for number of levels, Mehmet, for number of levels that you do laminectomy, would you consider fusing them?
Some biomechanical studies are saying that 3 levels. Some others saying 2 levels. But if it is together with laminectomy, total laminectomy, then it's really very important. I don't think there is good evidence that with unilateral approach, bilateral decompression, and sometimes you can jeopardize one facet joint or 2 facet joints. Do they really make too much instability? We don't know that.
Okay, and there's another question regarding non-instrumented fusion. Is it still used, and is it worth it? And are there complications associated with non-instrumented fusion?
This is the Epstein study. Actually, she was stressing that non-instrumented fusion is better for elderly patients, for more than 70 years old. But there are still surgeons using that. I don't use any non-instrumented fusion.
Okay. There's another question regarding what is your experience with failed lumbar spine syndrome after treatment of disthesis? How would you decide pain control measures, lumbar neurostimulators, how would you treat these patients that you've operated for diseases and then they come with failed lumbar spine syndrome?
This is a good question, but to answer that question requires another talk, another 1 hour. There are many aspects of it. If the main problem is a neuropathic pain, you can start with the gabapentin or pregabalin, and then stimulator must be the last resort. Actually, although some people are very fan of stimulators, but their effect diminishes by the time, and after 1 year, 50% of them are effective. So then I try to find the main source of the pain mostly, and try to rehabilitate the chronic pain behavior together with psychiatrists. It is one of the main problems of that chronic pain patients. And it needs a very multidisciplinary approach, actually.
Okay, there you know in your talk you talked about obesity and females are as one of the factors. So how would obesity in females make a difference?
I am not sure for that, but some studies are saying that in the female patients, the ratio of instability is much more than the males. This is because of that. I don't know the explanation of that.
Okay, all right. Doug, have you got any comments?
A couple. I hate the term failed surgery syndrome. It isn't a diagnosis. And in patients who have bad results from surgery, you need to figure out why they had a bad result. If they had a surgery that didn't work, like the goals of surgery weren't accomplished, they didn't adequately decompress, or a fusion that didn't heal. Is it somebody who should never have had a surgery in the first place? A chronic pain patient who had an MRI abnormality, but really the pain pattern didn't fit. And I think in the biggest thing of in the quote failed surgery syndrome patient is to figure out why they failed. And then you'll find out it wasn't the surgery failed, it was something else. And that's, I think, the other one I wanted to mention, when people talk about lumbar stenosis and back pain and whether decompression alone will treat back pain, you have to look at the pattern of the back pain. So if you have somebody who has a true mechanical back pain, so pain made worse with changing positions, it's equally worse with any loading of the spine, so sitting is equivalent to standing. Those patients, that's a mechanical back pain. The other back pain that a lot of these patients will get is what is essentially a claudicant back pain. If they are sitting, they have no back pain. If they stand or walk for a prolonged period of time, they have a back pain that goes away immediately upon sitting down. These are patients who are getting back pain because of their compensatory mechanism for their stenosis. They're leaning forward, they're overloading their back muscles. These are also patients who are fine pushing a shopping cart. They don't have back pain when they're pushing a shopping cart or using a walking stick. Those are patients, that pattern of back pain will get better with the decompression alone.
Okay, I think it's a very valid point. I totally agree. Atul, have you got any comments? Can we unmute Atul and get his opinion in this? Mauricio is here as well. So, Imad, can you please unmute Atul?
Okay, Salman, can you hear me?
Yes, we can hear you.
Same, I enjoyed the lecture, but I'm a little bit surprised that my recent work on lumbar canal stenosis was not quoted by my dear friend Mehmet, and not, the concepts in my article were not at all touched. You see, my concept is very clear and I have no doubt. Salman, you better listen what I'm saying. That lumbar canal stenosis is a phenomena related to lifelong standing human position. And the muscles of the back which are controlling the lifelong sitting position, abuse, disuse, and misuse of those muscles are the bottom line of creation of lumbar canal stenosis and degenerative spine in general. So my concept is that vertical instability, which is not recognized by radiology at all, you do whatever dynamic imaging or flexion, extension, you do whatever, is not recognized by imaging, is the basis or the nodal point of pathogenesis of lumbar canal stenosis. So that is one issue. My concept is absolutely clear that decompression is a negative treatment. Only fixation, multi-segmental fixation, is the treatment for lumbar canal stenosis. And I wish and I hope you refer to my publications, which are several in the recent past. And little bit, I know the experts of lumbar canal stenosis and spine are sitting right in front of me, but I will like all of you to have a look at those papers, try to understand what concepts I'm proposing. Whatever, whether you want to read or whether you want to follow, that is different. But as far as I am concerned, absolutely clear that only fixation is the treatment. Decompression of any kind, whether you want to do midline decompression, whether you want to do facetal decompression, is a negative form of treatment. So that is my comment. Salma.
Yeah, okay. I think, Atul may be right in some of these patients, but, and I think you really can't
I am
say
not
that.
saying some of these patients, Salman. I am saying in all
We
of
have
these
to prove
patients.
it. Okay,
And
let's prove
no
it.
proof. It is a publication and it is in Neurosurgery, Journal of Neurosurgery,
Sure.
and also in several other forums. So you cannot neglect or ignore a published article. That is a, that is a bottom
We're
line.
not saying that. No, I'm just saying that, in some of these patients, every patient has a different pathology, and when you look at not
Okay,
every patient
Salman,
is going
just
to have
let me, because it is
instability.
important,
Sure.
let me make some more comments. See, our psyche, our lifelong psyche in spine surgeon is that compression is the problem, decompression is the treatment. This psyche has to be changed. Compression is not the issue. Compression is not the problem. Compression is secondary. Compression is a radiological phenomenon. It is secondary to vertical spinal instability. And one must try to understand this new concept. And this new concept will not be taken by everybody just like that. When somebody is saying, yeah, I agree, I was doing decompression for 50 years, now I say, it is not going to happen like that. But it is a right forum for me to give my philosophy,
Sure.
give my concept, which is not based on 1 or 2 or 3 patients, which is based on multiple patients over several years. So you please try to think about it. Maybe you don't agree. It is not necessary that everybody should agree and everybody should say, yeah, very good, very good. Nobody should agree, but at least there is a point to think about.
Sure, we'll do that. Mehmet?
Yes, I know that concept, but actually, Atul is also doing a different type of fixation, facet distraction fixation.
No,
Not,
Mehmet, no, not facet distraction.
pedicle screw fixation?
No pedicle screw. It is transarticular facetal fixation.
Yeah,
Cannula technique.
transarticular facetal fixation. Sorry, yeah, I must correct it. But what do you think about pedicle screw fixation?
Pedicle screw fixation also can be done. The concept remains the same. The technique, you change the type of fixation does not really matter. But you know what I do is, earlier I used to introduce intrafacetal spacers, as you know. Used to distract and put intrafacetal spacers. The concept was that it reduces the vertical instability and stabilizes. But as I progress in this business, I realize that there is no need for even distraction, only fixation, and facets are the strongest point of the whole vertebra. Pedicles are not. Vertebral body is not. Facets are the strongest. You hold the bone, the facets are like rock. Vertebral body is not like a rock. Pedicle is not like a rock. So transarticular fixation, a technique devised by Camille, is the best technique for fixation, and that is my concept.
Okay. Doug?
Bullshit.
Okay.
No
Facet
question.
fixation,
Yeah,
facet fixation biomechanically, when tested, is inadequate for true stability. Creating fusions increases adjacent segment degeneration, particularly if you aren't restoring alignment when you create your fixation, or when you do your fixation, and facet fixation does not alter alignment. It's, yes, there are some patients who will get better that way, but this idea that, we have had the long history of success of decompression alone. To me, the morbidity in the long term of fusing people or stabilizing people does not make sense for something where we can do a relatively small, minimally invasive decompression, which has the best proven results in the literature for 50 years.
But Doug, you know what? You said right, that they have effect and they are being treated. But there can be a change in idea, there can be a change in thought, and to say bullshit and all this is kind of a retrogressive thing.
Show
you know
me,
what, Doug?
Show me
Doug,
the randomized control. No, we're doing science here.
I used to.
We are doing science here, Atul.
The whole world was.
Here.
Yeah, of course. These are published articles in
there's
Journal of
bullshit
Neurosurgery.
Published in the journals all over the place.
Maybe we can, see a few cases, and maybe based on the cases we can discuss what we can do and what we.
No, other thing.
Shall we progress to some cases, Salman?
You know what? We're doing science.
I think let's move on.
This talk will not.
This subject, no. So Atul,
one point. I just want to make one point.
Sure.
Atul, when you have done a 500 patient randomized controlled trial showing that your method is better, I will believe it. Until you've shown me an equivalent of the sports study.
I have proposed an idea.
Randomized
it
controlled
is on
trial.
You whether you accept it or you don't accept it, or if you have a air of superiority in your character. That is different.
No.
But you know what?
Atul, I'm sorry.
No, don't have to show.
Randomized
You are
controlled
nobody
trial.
for me to show.
That is the standard.
I have not to prove to you what I have to say and what I don't have to say. I have published
my dear friends,
20 articles.
Please.
You see in those articles. I don't have to prove.
I think obviously we can't discuss this in this webinar alone because the subject is completely different. But I think what we need to do is we all need to discuss this, read up, and then have a discussion. It will not get solved in this webinar alone. So I think let's move on.
This is eternal topic, like to be or not to be. So it's going to be always. That's what I discussed when Mehmet suggested this topic. My comment was, this is a topic like, the Shakespeare's question, to be or not to be. So, and I don't think we will find the unequivocal answer anytime soon. So maybe we can see now a few cases, someone. What do you think?
Yes, sure. We can start with Stacy. Stacy is going to show a case, and then we get Doug to show some cases for us. Stacy, can we unmute Stacy and make her? Yeah, she's now a co-host.
So, okay. Sorry, yes. Please unmute Stacy.
Great, thank you. Can you hear me?
Yes, we can hear you. You're welcome. Stacy is from Dublin, now working in Dublin at the moment. Yeah.
Yeah, so she's a senior fellow at the minute in Dublin, and
thank you
she's
for the
doing
chance to present.
Senior fellowship in spinal surgery. Stacy, please continue.
So this is a lady who presented to our clinic just a couple of weeks ago. She's a 50-year-old lady who presents with some very mild back pain, which is a bit mechanical and sounding, and some bilateral leg pain. But the more worrying feature was that of several weeks worth of fecal incontinence. So obviously the mind has to go to things like cauda equina. So this was the MRI scan that she presented with. And as you can see, she's got a 4-5 sort of grade 1 sponding, a bit of ligamentum hypertrophy, a bit of central canal stenosis, but nothing that you would say definitely cauda equina. So from what Professor Zileli's gone through today, you would say obviously she's female. So she has sort of decision making in terms of fusion versus decompression. She's likely to progress. She has radicular pain. She has back pain. So as a practice for us, we get standing flexion extension views. And if I can click this on, so you can see she has quite marked instability. So this was actually quite an easy decision-making process for the to fuse or not to fuse. So as you can see, her flex-X views are really quite unstable, and certainly would explain some more of her some of her symptoms. So when she was admitted from the clinic, she was in Asia L1D, and she went on to theatre.
Okay, so Stacey, hold on. Let's get some opinion from people out there. Guys, what do you think? What are you going to do from here? Have you got any takers? Anybody who wants to take this case, raise your hand and we'll unmute you so we can hear from you. How are you going to solve this case? Stacey, just briefly tell us again what's happening with this case again so that people can raise their hands who want to answer.
A 50-year-old female with mild back pain, some bilateral radicular symptoms, some fecal incontinence for a number of weeks intermittently. She's quite a high demand patient. She's otherwise fit and well. She's working full time, and she's a pre-op. She's Asia L1D neurologically.
Okay, any takers? So Pragnesh Bhatt wants to answer. So let's see, let's unmute Pragnesh. Imad, can you unmute Pragnesh, please?
Yes, sir, I'm trying. He has to unmute. Yeah.
Hello, are you able to hear me?
Yes, Pragnesh, we can. Welcome.
Good afternoon and good evening. Thank you very much, Salman and all the faculty. I would do L4-5 decompression and fusion because there is severe stenosis. I would do a standard open posterior approach, wide decompression to give the benefit for the cauda equina decompression, and do a standard posterolateral fusion. What I'm not sure is whether I'll be able to put a kgs because I need to look at the MRI back to see the disc height. But my plan would be to do a good decompression and a posterior pedic fixation. I can see that there is a disc height, though, so I would try to insert kgs as well.
There's somebody who said about dynamic fusion. So Doug, what do you think about dynamic fusion here? Sorry, you need to be unmuted.
Okay, there we go. Dynamic fixation means many different things. So I would need to be a little more clear. One of the commonly used dynamic fixation techniques, the Denosis. The Denosis was subjected to a FDA-sponsored IDE trial, and it was shown to be inferior to fusion in degenerative spondylolisthesis.
Okay, right. Any more takers? Do we have anybody else who wants to take this? So Pragnesh wants to do a fixation and plus minus cage, maybe PLIF, TLIF, whichever way. Nikolai, what would you do? Aftab Yunus from South Africa wants to say something. So can we unmute Aftab Yunus, please? Imad, can we please?
Unmute.
Aftab, are you there?
He's unmute.
Okay, yeah,
Yes,
thank you.
yes, Aftab, please.
Thank you for giving me opportunity. First of all, it's a dynamic instability. Dynamic, fusion is contraindicated in this case. So I will do PLIF with the single segment fusion, posterior fusion. But I do MIS through tubular retractor. You can put a cage in there, and also you can do a minimally invasive spinal fusion in this case. So that will be my approach for this case.
So Aftab, you're going to do TLIF or PLIF with minimally invasive?
I'll put in a usually what I do is I put in a TLIF from the side as well. PLIF got a lot of complications, so I prefer to do a TLIF than PLIF.
Okay, so let's see what Stacy did.
So yes, it was instability. So it was her intra-op. So obviously we went on to fuse. And so we did not do minimally invasive because the consultant I was with doesn't really do a lot of minimally invasive. So it was an open procedure, decompression, fusion from the back with pedicle screws, as well as interbody fusion with a TLIF. And I know that talk about the sort of open procedures taking longer to go home. So she was neurologically Asia E the day after surgery, and she went home day 2.
Okay, any comments?
The only thing that I can comment to that is it would be good if we can see, in these cases, dynamic MRI scan. So if there was a dynamic MRI scan, I am sure that, especially seeing the dynamic X-rays, you see significantly reduced cross-section of the spinal cord, and that probably can explain the neurological symptoms, most likely. So I think this was a good solution, minimal invasive or open. Professor Zileli said that in long term, and the end goal is more or less similar, and whatever works in your hands. In my hands, this will be minimal invasive, but we can see that open works pretty well as well. So it's a matter of choice.
So Nikolai, many young people would be asking this patient has got severe problems, cauda equina. Would you still do minimally invasive?
Yes, because probably if you deeply start asking this patient, probably this patient will tell you that he has problems only when the patient is upright, because when the patient is upright, that slip happens. You can see that when the patient is in a supine position on the MRI scan, the situation is not so bad. But when you see the standing X-rays, you see significant slip there. And that is probably what's contributing for significant compression of the neurostructures. So yes, I would do minimal invasive, and in my hands, I think this will work good. And I have similar cases I can show.
Okay, Mehmet, are you there? Would you be able to comment on this, please?
Yes, actually, I would do the same surgery. Yeah.
Okay, good.
Interbody fusion plus short fixation.
Okay, very good. Thank you, Stacy. That was wonderful.
Just to be contrarian, another option here.
Sorry.
So probably with the degree of central stenosis, I probably wouldn't. But a lot of these patients with dynamic instability, dynamic compression, essentially, another really good option is an ALIF with percutaneous screws.
Yeah.
So you'd consider indirect decompression even if somebody is cauda equina?
I wouldn't with cauda equina. That's what I said. So what I do is I look and is their dominant stenosis foraminal and lateral recess? If their dominant stenosis is foraminal and lateral recess, I will consider doing an anterior interbody of some form with percutaneous screws. If they have severe central stenosis, I tend to do them as a TLIF.
Okay, so thank you, everybody. I think we move on to cases. Doug, have you got some cases to show us?
Yeah, okay. Okay, if you would let me share my screen. Share screen, here we go. Okay, so I've got 3 cases. I sort of did this as a hoping that Mehmet would say a lot of the things that he did say, and so I sort of picked the cases. So the first one, this is a 64-year-old male. He complains of activity-related bilateral lower extremity paresthesias, unsteadiness, and weakness. He actually says it doesn't really hurt. He just can't walk very far because his legs get all wobbly. His walking tolerance is less than 100 meters. His standing tolerance is 5 minutes. These are upright x-rays. And then I'm going to go through his MRI. What you can see, that's a mid-sagittal T2, and then axial T2s. This is L1-2, L2-3, L3-4, and L4-5. So what do people want to do?
Okay, anybody
Does
wants to
anybody
take
want any
this?
other investigations?
Anybody wants to raise their hands and answer?
Can you
Any
show us again the 3 level while we are waiting?
Okay, it's actually 4 levels. Here's L1-2,
Okay.
L2-3, L3-4, and L4-5. L5S1, widely patent, T12L1, widely patent. So it's just these 4.
So Vinod Kumar says we need MRI of dorsal spine.
The MRI of the thoracic spine is fine.
Okay, Pragnesh wants dynamic x-rays.
Okay. So here's flexion extension views.
Looks good.
Yeah.
Okay, so we have stability.
Oh, another
here.
point I wanted to bring up on flexion extension views. Actually, no, I'll bring it up later. Never mind. It's okay. So what do people want to do?
Sorry, Doug, is there any lateralization of the symptoms, or it's just bilateral?
No, it's bilateral.
And is there any weakness, or is just pain?
He has no documented weakness, but he perceives his legs get weak. He says if he stands and walks, his legs feel weaker and they get wobbly. But if you just test him statically in the exam room, he's 5 out of 5 power. What I will do sometimes in these people is have them go walk and walk 100 meters and then re-examine them. And sometimes you will find that after they've walked for a little while, they do have a little bit of true weakness.
And how old was that patient?
Sorry?
How old was the patient?
64.
64.
Otherwise completely healthy.
What about the spine balance? That's the question. Do we need whole spine x-rays?
So whole spine x-rays. So again, it's he when on clinical exam, you can easily get him to stand in neutral sagittal and coronal balance, but not for very long. He really always wants to be leaning forward.
Okay, but okay.
But scoliosis films, he is able to stand in neutral sagittal and coronal balance.
Okay, Stacy says no back pain, but claudication symptoms,
No actual pain.
Decompression only.
Decompression only. I
There's
agree
a
with
suggestion regarding a brain assessment. Why would you do brain assessment with that clear a pathology?
In fact, it is almost same that I have shown during my talk.
Yeah.
4-level decompression.
Yeah.
Yeah.
This site is quite narrow, and there is no instability. There is no back pain. So just decompression. It may be even done with an open surgery or minimally invasive.
Probably the patient is leaning forward because he's decompressing like that for the foramina. And
Oh,
that's
absolutely,
real.
yeah.
Yeah. So just decompression will be perfectly okay. I agree with that.
So MIS or open?
That depends on the preference.
I think dealer's choice.
No need for fixation. There are some suggestions from the audience. This is a typical case that there is no need for fixation.
So I think to some extent, I think one of the things is there are decompressions and there are decompressions. I think if you were to do a 4-level complete laminectomy, that would have a relatively high incidence of failure. And particularly, I would be worried about progression of the degenerative scoliosis. I think that if you can preserve the midline structures, either by doing bilateral keyholes or unilateral approach bilateral decompression, I think that a multi-level decompression is a very good is probably the better option here.
Okay.
There is
If
also
you are
slight
not
rotation.
using- There comes some suggestions from the audience, multiple laminectomies. Actually, I don't accept in the current knowledge to make multiple laminectomies for a patient like this.
Yeah.
And demonstration you must do.
The reason I've always disliked laminectomies is that as you look here, if you look in between where the lamina is, he's not stenotic. So laminectomy is faster. You know, you can do it much more quickly, but you're essentially decompressing areas that aren't compressed, and so that's why I think just interlaminar decompressions are a better way to go. And also it's whether people do, what I notice at least in North America is whether people do midline preserving decompressions or not is a function of how many revisions they do. The more revision surgeries you do in your practice, the more likely you are to preserve the midline, because I'm always thinking anytime I do an operation, okay, if there's another operation, what am I going to do? And boy, if I've preserved the midline structures, it is way easier to do the next operation than if they've had a complete laminectomy.
Yeah.
Okay, their question is, what about D12 L1? Could that be calcified disc?
There isn't. This is because of the scoliosis. This is a little off center. When you actually look, and that's actually 11, 12. We did do a thoracic MRI, and there is no compression.
Okay, good.
Okay.
So everybody
Next.
agrees? Yeah.
Next one. Okay. It's a 58-year-old male. He's got a 1-year history of activity-related back pain, and the back pain is that claudicant type back pain I was talking about. When he is sitting or when he's getting in and out of bed, he has no back pain. The back pain is only when he's standing or walking. Bilateral lower extremity pain, slightly worse on the left than the right. His walking tolerance is limited to 200 meters. His standing tolerance is about 10 minutes. He has tried anti-inflammatories, pregabalin, physical therapy. He's had epidural injections, which provide about 2 weeks of really good pain relief, but not durable relief. Here are his x-rays and his MRI. So, anybody want anything else?
Okay, any comments, please?
Nobody commenting.
Okay, clearly there is open facet sign there. Even on the MRI scan, you can see that there is a degree of listhesis at L4, L5, which corresponds to the
Actually,
open
in the
facet.
MRI, he doesn't have a listhesis at 4-5.
Well, there is
Fine,
a hint for that.
He's neutral. He's neutral in the supine position.
Yes.
And listhetic, and that was 9 millimeters in the standing position.
Yeah.
So
Okay.
this is one point I wanted to bring up. And I wish I could remember the reference, but you are substantially more likely to detect spondylolisthesis comparing a supine to a standing study than you are a standing flexion extension.
Yeah.
So in a case like this, I was wondering if people were going to ask for flexion extension. This is one where you don't need flexion extension. You know this is unstable.
I agree with you. This for me will be a single level fixation, some sort of interbody fusion.
Yeah, and this to me is the perfect patient, though that's not what I did for this patient. Historically, Now this is a patient in whom I would do this as an ALIF and percutaneous screws.
Okay, Mehmet.
I understand on the flexion extension, there is no movement.
I didn't do flexion extension because there's movement just comparing this supine image to a standing image. He has 9 millimeters of instability.
Okay. Okay, but I would rather the patient has back pain additionally.
Claudicant pattern back pain, yes.
Yeah. I would rather do a short fixation with TILIF.
Yep. I don't think there's anything wrong with that. And in fact, that's what I did with this guy. I did this as an MIS TLIF. But as I'm saying, now I would have done this as an ALIF with percutaneous screws.
Okay. It's another option.
Yeah, we know that Doug does a lot of ALIFs. He's used to that. And so as somebody who's used to that should, do whatever works best in their hands.
Yes. The one fusion technology I would not use here is this is one where I would not use a transpsoas lateral. And the reason for that is that this is the so-called Mickey Mouse ears sign. The psoas is anteriorly shifted on the disc space. And so that in order to get at the disc, you're in the posterior third of the psoas. And so the chance of an L3 nerve root palsy, even with monitoring, is very, very high here. So this is one where I would not do a transpsoas fusion.
What about
can I
OLIF?
ask you,
You
what
think
is
OLIF is difficult here because of Mickey Mouse appearance of the source?
OLIF is harder again, it's very difficult with the psoas that anteriorly to do the OLIF, but it's better than going transpsoas.
what is your indication for ALIF and why you prefer ALIF instead of TILIF?
For me, ALIF, 3 reasons. One, highest fusion rate of any fusion going. If you're going to do a fusion, you might as well do the one with the highest fusion rate. 2, with a mini open technique, this is a one-night hospital stay. In standalones, I've actually had patients go home same day with a standalone ALIF, so outpatient surgery. And in this type of patient without central stenosis, in my hands, it gives good results.
Okay, good. Let's move on.
Okay, and then this is the last one. Oh, there's the foraminal view. So this is at this time I did this. I had actually done this one as a minimally invasive TLIF. Oh, sorry, that was the 3rd thing. And that this X-ray reminds me. The other reason I do ALIFs is it restores lordosis better. And I think that the restoration of lordosis that's the adjacent segment degeneration is, some of it is natural history of the disease, but I think a lot of it is not the fact that we're fusing people, it's the position we're fusing them in. And what I hate about this X-ray is in this standing film, top of L4 is not parallel to the floor.
Have you tried expandable cages?
I actually, the biggest thing I've done with my TLIFs is I've stopped using the straight ahead cages, because the straight ahead cages like this one is, they give you the lordosis you're going to get. And I've gone exclusively to crescent shaped cages as far forward in the disc as possible, and then compressing down with a bilateral facetectomy in my TLIF patients to get the lordosis.
On top of that, you can have also some expandable technology. And
problem with expandable cages is that in the United States, an expandable TLIF cage is $5,000. My peak crescent cage is $500. My hospital's profit margin, and in the American system, that's important, my hospital's profit margin on a 1-level TLIF is about $2,000. So as soon as I use an expandable cage, my hospital loses money.
It's amazing how different places are different countries. In the UK, expandable cages vary around 2,000, so it's not this expensive.
Yeah,
still expensive.
Still expensive, yeah. Comparing to, but
I just can't rationalize the excess cost.
Yeah, I think the results are the same at the moment.
Yeah. Okay, this is the last one. This is an 80-year-old woman. She's coming in with bilateral, slightly worse on the right, anterior thigh pain with activity. Walking is limited to 50 meters, standing limited to 5 minutes. Here are her x-rays. And these two axial cuts are just below the disc and at the level of the disc. And you can see that she has facet cysts here and here. So what do people want to do?
Any takers? What are we going to do? What do you need? Any other investigation? Dynamic.
Okay.
Mohammed
So I
Asif,
actually did do FlexX on her. And there's really only about 1 millimeter's difference between the flexion and extension, maybe
so
2.
Not much happening. Okay.
Not so much, yeah.
So where do we go from here? Any more takers? So Alessandro says just decompression, steroid injections.
She's had steroid injections. They helped for about a week.
And then
which level?
Carlos is saying
At 3-4.
percutaneous fixations. Ozair says injections only.
What injections did you have exactly? What injections did you do?
She had a bilateral L3-4 transforaminal epidural.
Okay, but that's an answer then.
Felt great for a week.
That's pretty diagnostic then.
So your conservative treatment in this patient, how long would it be if you're going to do conservative treatment?
Another option to mention when you're doing injections in patients with facet cysts is there's actually a growing literature on essentially injecting the facet joint and filling it full of fluid and actually bursting the cyst.
But there is also literature suggesting that if you see a cyst that is potentially unstable.
Yep. That's why I'm presenting this particular case.
So there are a lot of studies now coming from Korea regarding minimally invasive transforaminal decompression and taking the cyst at the same time and not fusing and saying that results are reasonable, but the numbers are really small at the moment.
And with no control group.
With no control group. Mehmet?
Yeah, in an 80 years old, we must be cautious for doing fixation surgery because she must have osteoporosis at this age, a lady. I'm not sure what to do.
Okay,
really.
Doug,
do you have you measured the bone density here?
I have not on this case. If I was contemplating doing a fusion, I would have gotten a bone density.
Right, so you're betraying your decision now. You're saying that.
Yes. Yeah. No, I
So there's a question about cannulated screws.
Yes, cannulated screws plus augmentation could be an option if somebody wants to fuse in that age and is concerned about bone density, obviously.
Treating the osteoporosis is a better option.
Well, but you need a lot of time for that.
So if I think particularly in my deformity patients now, if they're osteoporotic and I'm contemplating a deformity surgery, they're all going on an anabolic agent, such as teriparatide or abaloparatide or rosasuzumab. If they're really miserable, I put them on that for 3 months. If they can tolerate it, I put them on it for 6 months and sometimes even a year before I operate on them.
Yeah, I think generally what I do is 3 months and then they can continue afterwards as well.
Yeah.
Ipan from Indonesia is saying that injection with pulsed radiofrequency or on DRG.
not familiar with that.
Just
So-
1 week of relief of her symptoms. Did you say that after the injection?
Yeah, 1 week after the injection. So I did this as a bilateral keyhole foraminotomy, and she was doing really, really well for about the first 8 months. And I just saw her back this week, and she actually now does have a mobile spondylolisthesis. So yes, I'm getting her bone density tested because I have a feeling she's now having true mechanical back pain. And I think that in spite of trying to preserving everything in the midline, I think just she's gone on to develop an instability. So yes, they do develop.
There is a lot of publications coming from you as about measuring the Hounsfield units on a CT scan and then deciding. Do you believe in that? And what's your
Absolutely,
practice?
I do.
What is your cutoff?
So for those of you who don't know it, what you do is on your image software, there's usually the ability to capture an ellipse.
Yeah.
And what you do is at the level of the pedicle, you do an ellipse where you're not touching cortical bone, and it'll give you an average Hounsfield units within that ellipse.
What is your cutoff?
Anything under 135 is osteopenia. Anything under 105 is osteoporosis.
When are you going to augment?
Sorry?
When are you going to augment? If you
Almost
see that
never. I probably haven't augmented pedicle screw fixation. Certainly, I can't ever recall augmenting a single level pedicle screw instrumentation. And if I do augment, it's on my deformity patients, and I augment UIV and UIV +1. I don't do any more than that. And the reason for that is, if they fail, you've now taken a problem and made it a potential disaster. Because with the cement augmented screws, particularly the fenestrated screws, in the really bad osteoporotics, you take them, you try and take that screw out to re-instrument them to add on levels, and you can just completely destroy the vertebral body. And now you're dealing with an osteoporotic patient who needs a corpectomy. So no, I rarely use on single level degeneratives. And if I do use them in deformity long constructs, I'm only doing UIV and UIV +1, or if it's a thoracic where I'm coming down, I'll do the LIV and LIV +1.
Would you aim bicortical here in that case if you have to instrument, and in case the patient is with bad bone quality?
So interesting. If you look at if you read the product inserts on intervertebral body cages, they say not to be used in osteoporosis, because when they did the IDE trials, that was an exemption. There's a beautiful study done by Dave Pauly looking at rigidity of constructs and finding, actually, particularly if you can get a interbody spacer in the anterior third of the disc space, you create a much better, more rigid. So actually, most people say osteoporosis is a contraindication to interbody fusion. I actually think it's an indication. So rather than cement augmenting, particularly in somebody like this where the disc is relatively tall, rather than cement augmenting the screws, I would rather get interbody support anteriorly.
Okay, there's a question on the chat which is there for some time, so I'm sorry, I'll ask it again. It's what is the outcome of spinous process splitting procedure in lumbar spinal stenosis? Is it any useful? Mehmet, you want to take this? If you split the spinous process, so you're keeping the muscles intact, and you open it like you do it in cervical spine?
Yeah, I'm not against this, but I have no experience with that. I didn't do it. Splitting the spinous processes. Actually, even in the cervical spine, it is quite technically demanding. It must be more technically demanding in lumbar spine. Why do you try so difficult things instead of doing just fenestrations or minimally invasive unilateral approach, bilateral decompressions?
Okay.
Yeah.
Atul, if you are there, okay, if we can have a comment from Atul before we wrap up. Sorry, Doug, you carry on in the minute.
What I was going to say, this is one where bitter personal experience. I would not in this one do a unilateral approach, bilateral decompression, because the bilateral facet cysts. There's so often you'll get these where they're tightly adherent to the dura, and I can just imagine getting that terrible contralateral durotomy doing that. So that's why I did this as bilateral fenestrations.
Okay. Salman, you want me to make a comment and create
Yes,
another
please.
controversy?
No, don't create controversy. You can comment.
I'll tell you what, you know what, in this case, you know, whether you take it or you don't take it, that is on individual. But this patient, you know what is happening in this guy is this is an old man.
It's an old woman, actually.
Woman, huh?
Yeah.
Yeah. So the thing is, you know what, there is not much compression as such. What is happening is his muscles have become weak and there is an instability. My concept is that these cysts that you are seeing, this facetal thickening and whatever osteophyte in the region of facets, this bulging of the disc, this reduction of the disc spaces that you are seeing at multiple levels, some kind of listhesis that you are seeing between the bodies. These are all a result of instability. And this guy,
we can't hear you, Atul.
This person. Oh, you can hear me now?
Yeah, it's better.
Yeah, just a minute. This bulging of the disc, this osteophyte formation, this cyst formation in the joints, this hyperostosis and this joint, you know, this weakness of the facets, this listhesis of the body are all secondary. My concept is that these are all secondary to muscle weakness and vertical facetal instability. There will be no instability on dynamic imaging, but there is instability, and that is the genesis of the entire problem. There is no need to do any decompression. All these changes that you are seeing are all secondary to multi-segmental instability, and this person will improve by I do transarticular camillase technique of multi-level. I will fix him from L1 to L5, and that will be my technique. And believe me, you know, you don't have to, I'm giving you a thought and I'm giving you my experience. 100% this patient will have symptomatic relief, which will be lasting and which will be permanent. I know it is not a accepted concept and not a very popular concept because it is a new concept. But this new concept, believe me, Doug, you are my friend for a long time. Don't be upset. This concept, which I am proposing, is here to stay and here to stay for long. And this is my, you know, last sentence that I'm giving to you. I know I don't want to create a controversy. I'm not. You know, I said decompression is not necessary in craniovertebral junction. Many people said bullshit and all those things. And I'm used to, I said decompression is not necessary for Chiari malformation. And many people have not only criticized me, they have thrown stones on me. But I am absolutely sure that Chiari malformation, you don't need decompression. For lumbar canal stenosis, I am absolutely sure. And over 10 years, my experience is I don't need any certificate from anybody. This patient needs multi-segmental stabilization, no decompression of the cyst, no decompression from front. This patient needs fixation.
Okay, Mehmet. Thank you, Atul. Mehmet.
I know. I'm sorry, Doug. Don't worry, my friend. Give me a smile and get done.
It's always fun sparring with you, Atul.
But multiple level fixations may create new problems, especially adjacent level disease. We must have long follow-ups of those. If you fuse from L1 to L5, especially, shorter fixations are better, as I have stressed during my talk. Thank you.
Okay, Doug, could you please unshare the slides or show us what you did? No, this is what you did.
I
Okay,
told
so
you I did.
yeah,
I did.
okay.
I did lamb FRAMs. So I didn't have a post-op until I saw her this week, and I don't have her new X-rays. But yes, she now has a mobile spondylolisthesis, and
Okay.
I'm repeating the MRI to see if there's anything else I need to be worried about, or whether I'm just going to go ahead and stabilize her. My current plan for stabilizing her, if the MRI shows what I think it's going to show, which is not really any central stenosis, just the instability, would be a transpsoas lateral and percutaneous fixation.
Okay, agree. Can we, Imad, can you show us the MCQs, please? And Mehmet, you can take these MCQs away, please.
Yes. Among the statements below, which is not appropriate for minimally invasive spine surgery. The A is
Imad, can you please show us the full question? Maybe just, yeah, that's it.
A is the correct answer.
So at the moment, it's the superiority is not known. Okay. Mehmet?
Which feature below do not fit complex lumbar spine stenosis? Yes, sagittal facet orientation and severe facet denervation. Correct answer must be B. And lumbar spine stenosis patient, which factor below has less value for fusion indication? Yes. Yes. Preserve this kind.
Okay.
Sorry?
Less value for fusion indication.
Yes. Actually, you can consider as for female gender. There is some confusion here, but yeah, I accept this. Preserve this guide.
Mm-hmm.
Okay, next.
There are only 3 questions I have sent.
Okay, brilliant. Mehmet, I think overall the talk was very nice. We really enjoyed it. Say hello to Barna in the background.
Thank you.
And enjoy your dinner, I'm sure. And Nicola, your comments, Doug, your comments before we close.
Oh, very good talk, Mehmet. Thank you.
Very good
Doug.
talk and very interactive presentations and case discussions. And I think we really had a good discussion today, which, it became heated up to an extent. And this is always a good thing. When we discuss, we get the truth. So let's see when will be the truth in the future.
Thank you, everybody.
Can we just have a group photograph? Everybody switch on your video so we can have a group photograph. Imad, can you please take pictures? Everybody switch on their videos. And I need a big smile from Atul and Doug both. Thank you. Nicola, you can smile. It's okay.
I am smiling. Okay.
All right.
And in a fortnight, hopefully we will have Professor Zemchen and Yoko Morotel taking us through, and we would have the same team helping us.
Yes, sir.
Everybody, welcome.
Okay.
Are you done with pictures, Imad?
Have a good week, everybody.
Yes, sir, I'm done. Yes, sir, it's done.
Okay.
Can I stop smiling now?
Yes, you can stop smiling now.
So thank you, everyone. It was a pleasure. Really enjoyed that. And I think a bit of argument is always good for science. Okay.